Welcome to EuroPCR. My name is Lars Sondergaard. We're here to discuss the Lotus Valve, simplifying treatment strategy and optimizing outcome in the real world. I got two very experienced Lotus Valve user, Ted Feldman, Matthias Götberg. So Ted, could you start us telling about the technology?
Well, the title of the symposium, Simplifying Therapy, I think is really a big part of the spirit of the technology. The Lotus Valve is neither self-expanding nor balloon expandable. It's mechanically expanding. The frame is a self-expanding stent, but it's mechanically compressed to expand and locked into its final position. And this is done with a handle, open, close, very simple, completely retrievable until you release, which is unique among our valve technologies. And also importantly, when about a third of the valve has been extruded, it's functioning. So the instability that's part of either rapid pacing or obstructing the valve orifice with some of the other technologies is not part of this procedure. And I think that's the simplifying idea. So it is a novel technology.
So Matthias, what is the difference between this valve and other valves on the market?
So I would say the main difference with Lotus Valve is that it's fully repositionable and fully retrievable. In other words, you can move or remove the valve depending if you're happy with the end result or not. And some of the other valves on the market are at least partially repositionable, but this is the only one that will work and you can reposition and retrieve it in its fully locked and deployed state. So it's really, you can assess height to coronaries or PVL and decide whether you're happy with the final result or if you want to reposition.
So Ted, do we have any evidence how this valve is actually doing in the real world?
We do, and I should say one other feature is that the Lotus has an adaptive seal, around a plastic seal around the outside. As the valve shortens, the seal shortens and wrinkles to fill up the spaces of PVL, paravalvular leak. And this is what we see in the trial results. We have the Reprise trials, Reprise 1, an 11-patient feasibility study, Reprise 2, a CE mark trial with ultimately 250 patients, Reprise 3, a US randomized comparison with core valve, 1,000 patients. And what we see from feasibility is what we expect from a TAVR device, and that is a high degree of procedure success. And with the Lotus, a virtually 100% implant success because embolization is not possible when you can retrieve the valve. We see durable valve areas now in this early group out to 2 years, and hemodynamics that we would find typical for all of the TAVR devices, mean gradients in the 10 to 12 millimeter range. Reprise 2 for CE mark approval really defined this as the one valve therapy in large numbers of patients that has virtually no moderate or severe paravalvular leak. So in 250 Reprise 2 patients, one had a moderate leak at 30 days, and that was gone at 6 months. And we haven't focused on it, but as we're having more discussion about lower risk patients, there's also almost no mild paravalvular leak. So we have over 90% of the patients with zero PVL with this platform. And then of course the stroke and mortality are very similar to other devices. The biggest differentiator in terms of a negative that's we've seen with the Lotus trials is a relatively high pacemaker rate in the 28 to 30% range.
So the Lotus valve is maybe the valve which have the lowest PVL rate on the market, but on the other hand, Matthias, the pacemaker rate, at least in the initial report, was pretty high. How it is looking today? Has anything changed? Any techniques to bring it down?
Yeah, so really in the Reprise 2 trial, 250 patients, there was a 32% pacemaker rate after implantation, and it was really mirrored also in the responder registry of 1,000 patients, seeing a 30% pacemaker registry. One has to remember though that it's a new valve, we have a lot of new sites who are still learning how to use the valve. And as we gain experience with the valve, we also see in the clinical reports of significantly lower pacemaker rates. And this really mirrors what we saw in our practice. We started off with 18% pacemaker rates in our first 50 patients, but in the last 50 patients, we only have 8% pacemaker rates. And the main difference is that we avoid oversizing. In other words, we try to avoid LVOT overstretch. The other thing is that we try to implant the valve in a more cranial fashion and really trying to avoid the AV node altogether. So I think it's probably those two factors that account for low pacemaker rates. And we also have some other reports from Germany and England coming in demonstrating that we actually have comparable pacemaker rates with other valves on the market. So as we gain experience, I think we will start to see those numbers coming down.
So high implantation, less oversizing will bring it down in the same range as the leading on the market.
Yes.
What about new technology? Is there any new generation Lotus valve on its way, and how does that differ from the current one?
Okay, so we have the Lotus Edge that will be commercially available pretty soon. The main differences with Lotus Edge compared to the second generation Lotus, the current generation Lotus, is the introduction of a 14 French eye sheath or eye sleeve. So we will have a 14 French expandable sheath, and this will really facilitate the main limitation of the device so far, which is vascular access. So I think we will be on even terms with both SAPIEN 3 and Core Valve in terms of vascular access. Secondly, the delivery system is more flexible, so in the extremely tortuous anatomies we will have better tracking. Thirdly, one of the key features of the Lotus valve is the locking, the 3 locks on the valve. And one of the limitations has been during poor flora conditions that has been difficult to see when they have been locked. And this is something that has been remedied. So in this case, it would be very simple using one view to watch if the valve is locked or not. So it's really a natural evolve of the second generation Lotus valve.
So you mentioned 3 things: smaller seat size, flexible system, better visualization of the locking system.
Yes.
What about the depth guard? Can you explain, is that going to be integrated?
Yes, so depth guard is really a changing on how the valve is being extruded, flared from the delivery system. And what it really does is that it reduces the amount of ventricular foreshortening, which is observed with the current generation Lotus. So we hope it will be a more predictable way to implant the Lotus valve. So I think all these features together will help to simplify the procedure further with the next generation Lotus.
Ted, we're talking about where is TAVI on its way, and probably we are addressing in the future younger patients than today. We are treating patients around 80 years now, but we may move down to a patient who's 70 or 65 or even 60 years. How does a young TAVI candidate look like, and what special issues do we need to address, and can Lotus Edge be helpful in that?
Well, we have, as I had described, a very robust trial sequence up to now. Reprise 3 will see results in a year. We have the Respond registry, which really validates the trial results in a real-world group. And the Respond registry answers one of your questions, I think, or begins to answer one of your questions. We're starting to see the utility of the Lotus design in bicuspid aortic stenosis. And this is critically important as we move into lower risk patients where the frequency of bicuspid disease becomes more frequent. So the feedback that we're getting from Matthias and other operators who are able to push the limits a little bit is that the Lotus is very well suited to bicuspid and to some other difficult anatomies, horizontal aortas or heavily calcified left ventricular outflow tracts. So we do have plans for Reprise 4, which will be an intermediate risk trial, and then Reprise 5 ultimately for low risk patients with aortic stenosis.
Matthias, can you explain a little bit about why is Lotus a good choice for a bicuspid valve? What features is beneficial?
So first of all, the valve it's a slow release of the valve. So it's released in a very slow and controlled fashion. So first of all, if we're not happy with the results, if it's too high, too low, obstructing the coronaries, if it's the wrong size, we can always move it or remove the valve. So that is one key feature. The other key feature is the fact that it has a single braid design. And I'm not going to go too technical here, but what it does, it conforms around the point of resistance, in other words, the point of anchoring. So it will conform around very nicely like an hourglass surrounding this, which means it doesn't have a lot of radial outward force. But this is something that's very good in most of these settings. So really we can tailor the procedure in the bicuspid valves to fit for the Lotus valve.
Thank you, Ted. Thank you, Matthias.
Thank you.